I'm Dr. Richard Campo, the Neuroendocrine Tumor Clinic personnel up there. My background is nuclear medicine and internal medicine. We will be treating our first patient June 17th, our first MIBG therapy patient. And I'd like to kind of just in a short period of time go over a little bit of the in-service of the radiation safety aspects, and then the radiation safety officer, Mr. Charlie Reindell, will say a few words. We'll give you the pocket dosimeters to look at, and he'll demonstrate some of the radiation survey monitoring, etc. To start off with, MIBG is an old antihypertensive drug. It's a derivative of beryllium and guanethidine. MIBG stands for meta-iodal benzyl guanidine. And what we do is we hook an isotope, I-131, to this drug. This drug targets cancerous tissue, particularly cancerous tissue from the neuroendocrine systems, pheochromocytoma, carcinoids, neuroblastomas, etc. We deliver it by IV infusion. The radiation effects result from beta radiation. There is alpha, beta, and gamma you've probably heard about. Beta travels no further than 0.5 to 2 millimeters, so it doesn't come out of the patient. Gamma radiation, which we detect with our cameras, our nuclear cameras, comes out of the patient, and that's what we have to protect against. The remaining radioactivity in the drug that doesn't attach to the tumor will go out in the urine, also sweat, saliva, etc. In fact, about 85% of the MIBG that's not taken up by tumor goes out in the urine in the first 24 hours. The main indication, among others, but the main indication here at Kenner will be inoperable metastatic neuroendocrine tumors that demonstrate, by my scanning in nuclear medicine, demonstrate affinity for the radiopharmaceutical, MIBG. And that will be particularly here carcinoids, pheochromocytoma, other ones, neuroblastoma, will be much less. So, when you think of radiation, you're thinking about X-rays and that sort of thing, but actually there's an electromagnetic spectrum, and down at the lower end, with low frequency, we're dealing with radio waves, go on up the energy spectrum, microwave, to visible light, infrared, and above visible light, ultraviolet, X-rays, etc. Electromagnetic spectrum is shown there, but radiation is something you can't see, feel it, taste it, hear it, etc. It won't make you glow in the dark, and it doesn't make you radioactive. Okay. There are a lot of sources of radiation, sealed sources that you are familiar with radiation oncology, brachytherapy, the seeds that go in prostate cancers, cervical cancers, etc. Liquids, gases that you may know from emergency VQ scan. Ventilation is radioactive xenon, a radio gas. X-ray machines, of course, linear accelerators, etc. But the largest, the one that's most familiar is the so-called background or natural radiation that we get just living day to day. Those sources are cosmic rays, the sun, stars, etc. They're terrestrial radiation from uranium, other isotopes from natural background sources, and also our bodies. About 11% of our total load of 300 to 500 milligrams per year comes from internal sources, where actually we have some radiation in us naturally. To show you the vial here, it comes as a radioactive liquid. It'll be frozen when we receive it. The radionuclide I-131 is combined with the pharmaceutical, MIBG. Again, we treat it with neuroendocrine tumors. The large majority here will be carcinoids and occasional pheochromocytoma. MIBG takes the I-131 to the cancerous tissue where it delivers this beta radiation, killing cancer cells. We will infuse it over an hour and a half with an infusion pump behind lead bricks, and then we'll do a half-hour flush. So approximately 2 hours to deliver the dose. This is what it looks like. It's clear liquid, frozen. It won't be glowing. This is the nuclear medicine cart, which is kept in nuclear medicine down on the first floor. It's got casters. It rolls, so the technologist will bring it up. These are lead bricks, like in a rectangle. The infusion pump is down in, surrounded by the lead bricks. The infusion pump contains a 60 cc syringe with the radiopharmaceutical. There are absorbent pads around it. Again, it's kept in nuclear medicine. The room will be 401. We want minimal traffic into the hall. We have 410 and 411 as backups. These are portable, rollable lead shields, and we'll use anywhere from 1 to 3. They protect the staff from that gamma radiation and reduce radiation levels to adjacent areas, for example, rooms behind the walls, etc., if needed. Again, these are portable and can be rolled around appropriately. The bathroom is the main area that's going to become contaminated because MIBG goes out in the urine. We want to cover fixtures and all with cellophane. The phone will be covered, light switches. We'll have pads down on the floor. And this just allows faster cleanup at patient discharge. We have waste boxes, and there'll be one right inside the door, one in the corner, and probably one in the bathroom area. These are for the booties, the gowns, and the gloves, which I'll talk about, emptied daily by the RSO. This is the hall. This is actually a shot from Children's Hospital of Pennsylvania, where I spent some time watching these therapies of the children, generally with neuroblastomas. However, you'll always wear booties when you come in. If you're going to handle the patient, touch the patient, we'll ask that you wear gowns and gloves also. They're disposed before you leave the room at the door. In order to measure your dose, your radiation dose, we will ask you to wear a pocket dosimeter right here, which we'll pass around and you can look at it and read it. You'll wear it in your pocket, and you'll document the reading in a logbook at the door. When you go before you go into the room, you'll read it, put down 5 millirems or whatever it is. You go in, and when you exit, if it's 7 millirems, you put down 7. 2 millirems would have been the dose that you get. And we'll talk about this in questions. There'll be instructions for patient care. Everything stays in the room in general. Everything will stay in the room for monitoring with that survey meter by Charlie, Mr. Reindell. Anything that spills, we want to cover it. Don't try to clean it up. Cover it with an absorbent pad. Call the RSO or me. Our phone numbers will be on the door. Liquids, etc., should be, if the patient's drinking soft drink or something, it basically should be flushed down the toilet twice. We're doing the training, and pregnant nurses do not care for patients. If someone thinks they're pregnant or they're trying to become pregnant, they won't be caring for patients. Pam and I and others have decided this is a short stay, 2-3 days and we just to make things easy, because it's hard for the nurses to figure out how long the patients can stay in the room. You know, at Tulane, we've had patients, family come and get in the bed, and so it's just better, no visitors. This is going to be a short stay. Housekeeping and dietary don't even go in the room. All the trays, plastic utensils, etc., are kept and disposed and taken away by Charlie, who'll talk in a second. Staff have to wear the personnel dosimeter, wear disposable gloves and paper gown if you're touching the patient, booties always. The patient generally stays in the bed, and particularly the doctors come in and whatnot. We want them in the bed in general. They can use a toilet and shower. We don't want the nursing personnel to use that bathroom or any of it, the basin or anything like that. The patient can leave the room in an unusual emergency situation, a fire or something, but in general, he would only be going, he or she, to nuclear medicine, perhaps for a post-therapy scan. That'll generally be done a week later as an outpatient. Just so you know, the Nuclear Regulatory Commission sets the patient release at 7 MR per hour at 1 meter. The patient can be released. Anything handled by the patient goes into these waste boxes. Blood samples are not restricted. The internal exposure, first of all, it rarely occurs, but if you get things on your hand, excreta, patient secretions or whatnot, there's a potential that you could ingest that contaminated liquids. You'll generally always wear gloves if you're touching or handling, giving care to the patient. You prevent it, of course, by universal precautions, etc. Really occurs. Now, this occurs routinely. This is the gamma radiation that's exiting the patient. You can measure it with the dosimeter, and that's what we'll do. You go in there, you put your dosimeter on. How much is harmful? We'll talk about that after the presentation here. But in general, the nursing, you're going to spend 30 minutes per shift maximum. And the usual amount will be that you'll get is under 20 MR on a daily basis. A chest x-ray is 20 MR, for example, one AP chest view. To reduce the cardinal points of time, distance, and shielding, minimize the time you have to spend with the patient, maximize your distance as much as possible. 3 feet is nice. Shielding, those lead portable shields and all will be helpful. We'll talk a little bit more about this in the discussions. But radiation workers, nuclear medicine technologists, nurses that work with radiation, etc., perhaps in ICU and all, they have a maximum occupational limit of 5 rems or 5,000 millirems per year. Most nurses that work with this have less than 50 millirems per year average. If a nurse, say in specials, for example, gets a level at 75 millirems or above per quarter, which is measured on a quarterly basis, that's a notification for the Radiation Safety Committee. Again, an average person in the United States will get 350 millirems per year. You'll obviously get more if you live in Denver at 5,000 feet than you will in New Orleans, which is below sea level. Again, an average chest x-ray for comparison is about 20 millirems. A rem is a measure of radiation absorbed dose modified for a factor to be in men, and so it's called Rankine equivalent man. Just a couple of background things, and we'll talk about that. The normal incidence, I say normal, but the incidence of cancer in the general population is approximately 1 in 4. every third, every fourth to fifth patient, 20 to 25% going to get cancer. That's the natural. There's a natural incidence of leukemia, lung cancer, etc. They have figured out, they meaning the regulatory people, etc., that for every rem, which is 1,000 millirems, you will increase your cancer risk by 1/4 zeros minus 0.0, 1 in 40,000 per rem. So if I get 5,000 millirems, which is my limit for a year occupational exposure, whole body, not my hands or anything, over 20 years I'll have a 4% increase over my career, if you will. So that's a little bit of the perspective of background information. What to do in emergencies. The fluid spill occurs, cover it, don't try to clean it up. Call a radiation safety officer, phone numbers on the door. A code will be handled with normal procedures, and we talked about that, the dosimeters, if you're the person taking care of the patient, handling the code. These people are generally pretty healthy. It's going to be really extremely unusual that a code would occur. If the patient for some reason is moved from the room, the radiation safety people have to know about it. If the patient dies, obviously contact the radiation safety officer. That's really about it. I've got my email at mac.com, or you can call us up at 8500 with Pam and others. Okay, I'm going to turn this over to Mr. Reindel, who is the radiation safety officer for Ochsner Kenner.
Okay, my name is Charles Reindel. I'm the radiation safety officer here at Kenner, and you all have the handout about patient care. Just for comparison, natural background radiation levels are about 100 millirem per year. That comes from cosmic radiation, which you're hearing right now. That comes from the sun, other stars. Some of the background exposure comes from natural occurring isotopes like uranium and thorium in building materials and rocks. The other third comes from carbon-14, potassium-40 that you consume. It makes it possible, for example, carbon-14 dating of artifacts. Anyway, that's your normal natural background radiation exposure level. If you're working with radiation, your limit is 5,000 millirems per year, just to compare it to the natural background level. If you're pregnant, however, your limit drops to 500 millirems per term. That's only because the fetus is very radiosensitive. And that's why we say no pregnant people around these treatments. No pregnant nurses, no pregnant visitors at all. Radiation therapy procedures, we're contemplating two here. The big one is IA-131 for thyroid carcinoma or neurotumors. Contamination is possible mostly from the urine. Mostly comes out in the urine, the saliva, and perspiration. Stay time is generally about 30 minutes per shift, and we'll be issuing you a pocket dosimeter to record your exposure. I'm going to pass this around. This is simply a device you charge up with a little square box with a D-cell battery in it. Put it on the charger, electrode, tweak the potentiometer, and you can watch the fiber go to up to 0, or you can move it toward 200. You try to get it as close to 0 as you can. Right now, it's reading, that's about 0. Okay. I'm going to pass it around. Make sure when you read it, though, the 0 is on the left and the 200 is over here, because I've noticed that if you tilt it this way, gravity pulls it toward 0. If you tilt it this way, gravity pulls it toward 200, so you can get erratic results. 0 here, 200 there. You can pass that around and just take a look through it. Hold it up to the light. You have to hold it up to the light in order to see it. If you can't see anything, you've got the wrong way. And here's the book that you'll be logging these readings into. List your name, job title, the date, time in the room, time out of the room, your reading when you went into the room, and your reading when you went out of the room. So I'm going to pass the logbook around too. Generally, the dosimeter is clipped to the logbook, and it usually sits outside of the patient room, so the next person going into the room can grab it and use it. Just to see what you're going to get, this is an iodine treatment we did last week downtown. Ashley, somebody that was the main nurse, went in at 11:20. She came out 11:29. Reading in, dosimeter reading in was 8. On the way out, it was 8. She went in again for 2 minutes. It went from 8 to 9. The third time she went in, 10 to 10, 10 to 10, 10 to 11. 12 to 17, a little bit of a jump there, but you can see the readings are not that large, really. For the total treatment, the dosimeter went from 8 to 18. That's a total exposure of 10 millirems for everybody who went in the room. The limit's 5,000, but that's what we want to make sure of, that the numbers are trivial, they're small compared to the actual limit. Other precautions are there will be warning signs. This sign will go, or a sign like it, will go on the door, patient name, which room, extension to call, my number, or med's number. Visitors must check with nursing station before entering. That goes for housekeeping too. No housekeeping. They can't clean the room while they're in there. Everything that goes in is assumed to be contaminated unless proven otherwise. So what goes in stays in. This goes on the door. This goes on the patient chart. Basically, it's the same warning with numbers to call in case something unusual happens. In the first page or toward the front of the chart will be the nursing instructions. Everything has to be disposable. Private room with toilet mandatory. No visitors. No pregnant visitors. No pregnant nurses. No one adjacent within this distance. Pregnant nurses not allowed. Wear disposable gloves. Do not stand within 2 feet of the patient for more than 30 minutes per shift. That's just an old standby. Based on past experience, 30 minutes per shift, no one gets any large exposures. So that's the reason for the 30 minutes, I think. As for the rest of this, time, distance, and shielding, of course, the less time you're in the room near the patient, the less your exposure is going to be. The greater your distance from the patient, if you're right on contact with the patient, the dose is pretty high. But as you move farther away, the dose becomes less and less. Distance is very, very effective. Just step back as far as possible. But do what you have to do. Shielding, that's the lead shielding. I didn't bring my little slab of lead here to demonstrate that. That's about it. Does anyone have any questions about the procedure or about the dosimeter, the pocket dosimeter?